So in this video, I'm going to talk about rotator cuff tears and rotator cuff repairs. To start, we have to understand that for sake of mobility, stability has been sacrificed in the shoulders. And that's why a key player for shoulder function is the rotator cuff tendons, which are four tendons that keeps the ball at the top of your arm in front of the socket, and that's what enable us to undertake all the various movements we do on day-to-day basis nowadays. And that's why it is a very common problem that patients develop inflammation or tears in the rotator cuff tendons. Rotator cuff tears can happen because of wear and tear, especially in the elderly population. Also, it can happen after a traumatic event in all groups. Some patients might feel that they heard a click in their shoulder. Others feel and comes to me in clinic saying that they felt like something snapped in their shoulder. If that is the case, you lose power in your shoulder, you have pain, especially at night, you might find it difficult to sleep at night, and you have significant limitation of function, especially in overhead activities. A thorough examination and scans ranging from ultrasound scans to MRI scans can confirm the diagnosis. Surgery would be the best treatment option based on all the published evidence. In cases of wear and tear, we have the non-operative and the operative options. And we have different options to repair these tendons, ranging from bony anchors, sutures, and patches. In some patients where the tendons are irreparable, they need a thorough discussion, and we have other options from them, including a commonly performed option, which we undertake here as well, is a tendon transfer option, where we substitute the torn irreparable tendons with other tendons. And finally, if there is arthritis with irreparable tendons, then a reverse shoulder replacement is the treatment of choice for these patients. So on the day of surgery, we'll discuss the benefits and risks of the procedure. We will put you to sleep, and we tend to do nerve block, where we numb the nerves of your arm. What we tend to do in keyhole surgery is 3 to 4 stab incisions around your shoulder, where I stick a TV camera in the shoulder, assess all the aspects in the shoulder joint, and then we pass sutures through the torn tendon and fix the torn tendon to the bone. When you wake up, we'll keep you in a sling to protect the repair. The duration of the sling is dependent on many factors. This includes the quality of the repair, the tendon quality, the size of the tear, as well as other factors. You will go home in the same day. You will be in a sling for the duration agreed, and we start physio at 2 weeks. With physio, we start with pendular exercises. There is a safe range for the range of motion that I agree on with the physiotherapist. And in that safe range of motion, the patient can move their arm without causing harm to the repaired tendons. We mitigate the risk of stiffness. We actually enable patients to return back to pre-injury levels at a quicker pace. But it is balanced between protection of the repair as well as prevention of stiffness. Immediately after surgery, we encourage patients to do pendular exercises, which is small rotational movements of the shoulder, and that can prevent scarring and adhesions. But this should be done under the guidance of your physiotherapist. 80% of patients achieve 80% of function within 3 months, and the majority of patients will achieve 100% within a year. Return to sports usually is achievable within the first 3 months. For some contact or high physical sports, it will be somewhere between 3 to 6 months. It is a pretty safe procedure. The chances of success is more than 95%. There is a small risk of infection, which is significantly low in keyhole surgery, and we cite less than 1%, although it might be significantly lower than that. Risk of stiffness stiffness is around 3%, and that's why we undertake physio as early as 2 weeks from surgery. Risk of failure to repair, especially in massive tears, is one of the risks, but there are other options in this scenario. Risk of return on inadequate healing of the repair, which is low. And the good news, even in patients who had repair tendon tears which didn't fully heal, are usually asymptomatic as well.